Good morning to everybody. First of all, I would like to thank you, Professor Kinis and Dr. Skowronski, for a kind invitation to this wonderful conference. I would like to present a case of endovascular treatment of suprarenal aortic stenosis. Atherosclerosis is the most frequent cause of chronic limb-threatening lower extremity ischemia, and in vast majority of patients, these lesions are distributed in the artery below the takeoff of renal arteries. And the management of this lesion is well known and established. However, the suprarenal distribution of atherosclerotic lesion is rare. The traditional surgical treatment of such lesions is associated with significant morbidity and mortality, and possibilities of endovascular intervention are compromised by the risk of occlusion of the orifices of the extremely crucial splenic arteries. In this case, I would like to present a 74-year-old female with rest pain and non-healing ulcer of left lower limb that was classified at Rutherford 5. Her comorbidities included end-stage renal disease and hemodialysis for 11 years, hypertension, smoking 30+ years, hypercholesterolemia, and she had a history of bilateral common iliac artery stenting. Angio-CT was performed that showed the presence of heavily calcified stenotic lesions in those 5 through 8 of abdominal aorta, that is comprising the takeoff of celiac trunk, superior mesenteric artery, and both renal arteries, the atrophy of both kidneys, and patent stents in both common iliac arteries. It also showed a significant stenosis of left external iliac artery. In sagittal view, the calcification of the aorta is well seen, as well as the patency of superior mesenteric artery celiac trunk, and also the presence of anatomic variant, a separate takeoff of left gastric artery. The plan of treatment was to implant an aortic covered stent with chimney grafts to superior mesenteric artery and celiac trunk. Due to the atrophy of both kidney, we believe that coverage of renal arteries can be done safely without any harm to the patient. The procedure was performed under general anesthesia and hybrid operating room. Left common femoral artery and left axillary artery were surgically exposed. The patient was heparinized, and 12 French introducer sheath was introduced to left axillary artery into the descending aorta. A 6 French introducer sheath was introduced to left common femoral artery, and retrograde arteriography confirmed the presence of critical external iliac artery stenosis. The superior mesenteric artery was catheterized in lateral projection and balloon expandable covered stent 7/57 mm. Big peripheral was introduced over Rosen guide wire. Then, during the attempt to catheterize the celiac trunk, a left gastric artery was inadvertently catheterized. Luckily enough, due to the knowledge of existence of the anatomical variant, we recognized the wrong position of the catheter, and that protected us from erroneous stenting of the left gastric artery. At the end, celiac trunk was successfully catheterized, also in lateral projection, and balloon expandable cover stent 7/37 mm. Big peripheral was introduced over Rosen guide wire. Then we switched to posterior anterior projection to confirm the position of guide wires and cover stents. in SMA and celiac trunk. Then plain or balloon angioplasty of external artery stenosis was performed to facilitate the passage of aortic covered stent, and 6 French introducer sheaths in left common femoral artery was exchanged for 12 French introducer sheaths. And through that sheath and aortic covered stents, 16/58 millimeters bigger aortic was introduced, and then SMA, celiac trunk, and aortic covered stents were simultaneously deployed. Due to incomplete expansion of the aortic stents, we did post-dilatation also in the simultaneous manner of all stents, and completion angiogram confirmed the patency of implanted stents and branches of celiac trunk and sphenomesenteric artery. At the end of the procedure, the external artery was stented with self-expandable bare metal stent 9/60. A zero flex was used. Then introducer sheaths were removed and arteriotomies were closed with surrounding polypropylene sutures. The postoperative course was uneventful, and the patient was discharged home on the second postoperative day. The rest pain subsided and the ulcer started to heal. In conclusion, we may say that covered stents allow to treat safely and effectively a complex aortic pathology. And performing such procedure, one should be aware of possible anatomical variants. Thank you for your attention.